Okay, we should be going live now.
Yeah, says it's streaming.
Okay, let me just check. Okay, perfect. We're good to go. I can just... Right. Okay, right. So welcome everybody. We're live again. It's 5 o'clock. I continue my time slot, and we're planning just to continue on from the discussions over last week, which was really based around dentists starting off their dental implant journey. And we had Vishal on last week, and we spoke in length, but he still had some questions, and he was keen for me to sort of address those. So we're going to continue on. If you could post comments below. So what I've done today is a bit different. So I'm streaming through Zoom, and so I can get a split screen on Facebook, and on my phone I'm going to put up Facebook, so I'll be able to see the Facebook feed. If anybody has questions for me or for Vishal, then please just post them. So just post the questions in the comments below. Just to let you know, on Thursday I'm doing a live Zoom webinar, sort of going over what I feel would be the best way to start your implant journey, and then focusing on 5 key areas of assessment when we're assessing a patient for dental implants. So Thursday's Zoom group is complete. I'm limiting numbers, but I'm doing another one on the following Monday. So if you'd like to be added to that list, then please drop your email on the comments below. And remember, I will be uploading this video onto my YouTube channel, which I'll put a link for also afterwards. Vishal, good to see you again. Do you have a good weekend?
Yeah, it was great. Thanks, Ron. Thanks a lot. Once again, thanks for doing this. Thanks for taking the time out, for letting me kind of air my questions last week.
Yeah.
Very useful.
So just a bit of background. Vishal had a number of questions about starting off in dental implants, and he'd PM'd me privately, and I thought, you know, why don't we answer these live and try to benefit as many dentists as possible, because often you find there's a lot of people that have these questions, and if I can just answer, and then hopefully we can benefit as many people as possible. And thank you to Vishal for kindly agreeing to do that. So Vishal, fire away.
Sure. So talking about things which kind of people, general dentists that want to get into implant dentistry can do almost right away. So would you recommend restoring implants? Is that a great way of getting started into implant dentistry, or should you actually look at doing both side by side?
Okay, so yeah, really good question. So first of all, I think it's really important to note that I would consider, and the majority I think would be in agreement, that implant dentistry is a prosthodontic treatment, but it just has a strong surgical component. Yeah, so it's very much a prosthodont, because ultimately we're always planning with the end in mind. We always have to think of our final restoration and work backwards, and then working backwards we're able to determine where our implant's going to go. And I would say, yeah, absolutely, a good way to get started with an implant dentistry is start restoring, because implants are well placed, prosthodontically driven surgery. It's quite a simple task to learn how to restore a dental implant. If you have the right support within your practice, then yeah, absolutely, that's something you can start, you know, pretty quickly, without too much training required. And if you've got the right support in the environment that you're based, yeah, absolutely. I think if you see yourself going down a path of dental implants, then you know, absolutely start restoring dental implants,
Right.
because you know, at the end of the day, like I've said before, patients care about teeth. They don't care about the screw that's going into their jaw. Their focus is the tooth, and often that's the most rewarding part of implant dentistry, is actually delivering the final restoration.
Yeah, that's a very good point. Well, going on to that, so let's say a lot of us in general practice, we see a patient with a gap And we kind of think, look, this is going to be a suitable candidate either to take on a course to place implants on, or to offer an implant for the in-house oral surgeon to place and then you to restore. So kind of sourcing your first implant patients, basically. That's kind of something which we're all going to be thinking about if you want to get into implant dentistry. So is there kind of we touched on gaining valid consent last time, is there kind of like an accepted pro forma in a sense for gaining valid consent, like the risks, like we all know the risks for endo, for example, there are a multitude which you have to get the patient to be aware of. Is there any similar kind of things for implant dentistry where there's an outlined list of risks?
Yeah, so my consent process is pretty robust. The form is, I don't know, 4 or 5, maybe 6 pages long. Often after a consultation, the patients will get a letter outlining my findings on the day of examination, and then a treatment plan that we've already discussed that will be presented to them in writing. On that treatment plan, there'll be the total cost of treatment. And then it'll also go through a bit more detailed information about what is a dental implant, and then what, the treatment phases, timescales. And then the last section is a complication list, potential complications, and we break them down between the surgical and the prosthodontic complications. So they're broken down, and there's so many, but we go through them all, and I'm wary to tell the patients we list them all, but I verbally tell them about the main ones, or the ones that I feel are relevant to the surgery I'm going to perform for the patient. Because at the end, it's not about scaring patients off treatment, but it's making sure that they're informed about potential complications. So they're informed about them verbally, then they have it written in the consent form, and then the very last page of the consent form is somewhere for them to sign to accept the treatment plan, and somewhere for me to sign to accept the treatment plan also.
Would there be like a maintenance clause in there, so what they have to do to come back and kind of maintain them?
Yeah, so part of the sort of in terms of the guarantee you give with treatment is that they have to upkeep and follow a maintenance program with yourself for checkups and with the hygienist.
Have you ever had patients? What happens when the patients don't follow up in many cases? I guess
Yeah, I mean, certainly, you have to just be reasonable. But the majority of patients will follow things up. They've invested hugely, and they will maintain appointments, etc.
Yeah, am I right in thinking if you've kind of made them sign that form for the hygiene treatment, and then they don't attend, and let's say the implant fails in 3-4 years because of plaque factors, or they're not maintaining it, essentially, would you be on the line? Who would be kind of liable for that there?
Yeah, difficult one. I think that is difficult, and that's often the challenge with the treatment that we offer and consent. And patients can easily say, "Well, I don't understand that. I signed that. You asked me to sign it. I signed it."
Yeah.
So you have to, you just have to play it by ear, I think, and be reasonable. But thankfully, they're rare occurrences, and I think you just need to take it. What you don't want to do is aggravate a potential situation that's brewing by being, dismissive of a patient. I think you need to sort of just chat to the patient carefully and work something out, and work out something that's mutually agreeable in terms of how you're going to fix the problem or replace if it needs replacement.
Yeah, I think that highlights case selection is very important.
Yeah, absolutely, and I talk about it a lot, especially in implants. And I suppose for any kind of complex treatment, we should be looking into the psychology of our patients more. When we do full arch implant treatment, we give the patients a psychological assessment, and that goes through a number of things. But one of them is sort of looking at their mental well-being. It looks at their expectations, from the treatment, and to assess if they're unrealistic. And it also looks at the anxiety levels of the patient. So 3 parts to the questionnaire. And I think, it's probably useful to be adopting that within other aspects of dentistry, just to get an insight into the patient and their sort of mental or psychological status, because I think that's important. Because, patients could turn around and say, all sorts about you, denying, etc., and that can land you in potential problems down the line. And last thing we want is that.
True, very true. That being said, let's say a patient does come to you with terrible OH, which, to be honest with you, in general practice is most of my patients.
Yeah.
How successful are you at gaining compliance and kind of, I know motivational interviewing, getting the patient to see the value in it is the most important thing, but how kind of successful do you, in your experience, is this? Should you kind of hound the patients almost, and or should you just, if they're not going to change,
No,
say,
I
okay,
mean, look,
gonna...
I'm not short of implant work, and you have to empower the patients. It's all on them. And what I don't do is, if I'm not happy with the oral environment because of poor hygiene, then I don't do the treatment. You need a clean environment to be working. Why would I risk complications within my surgery by placing implants in an environment that's full of plaque and calculus? I think it's important before we do any of this treatment, we get the patient dentally fit. And that's, when so often I'm seeing patients and it's just for an implant assessment, but I do a full assessment. I look at all their dentition, their occlusion, the periostatus, and then I make that assessment. Are they stable, or are things unstable? Do they need to go back to their potential referring clinician for some redo of fillings or carious lesions dealt with, or do they need to see the hygienist? And then I will get them back for treatment. But I think you can assess compliance of a patient if they're coming in with a dirty mouth that's been uncared for and they've not been going to a dentist on a regular basis. You need them to demonstrate compliance, and you can't do that over a couple of weeks. They need to demonstrate compliance over a greater length of time, because otherwise you can do the best treatment in the world, it'll just end up pear-shaped down the line. So it's important that as clinicians we take responsibility. Ultimately, we are signing off for patients going ahead with treatment, and the onus is on us to determine. And it's not enough to say, well, I said to them, they cleaned their teeth, and I got them to the hygienist and cleaned everything, and now they've just not maintained it. No, I think I think that we have a responsibility to assess compliance as well with oral hygiene, and then especially when we embark on these treatments.
Smoking in terms of, I know it's a major risk factor, but there are lots of studies showing less than 10, more than 10, 90% success rate.
Yeah, so I have my own personal opinion, which I'll go into. There's the SAC classification from the ITI, which talks about 20, less than 10, and 0 in terms of severe, moderate, or low risk in the classification. Yeah, I look, there are implants placed in smokers all around the world all the time, and the majority of the time they work. But my own personal opinion is I don't treat smokers. As simple as that. Unfortunately, I'm busy enough with work. I give the patients an ultimatum. I need them to stop smoking before I place implants, because I don't want to risk my work down the line. It's as simple as that, and that's the way that I approach it. And so I advise them they have to stop smoking, and then I'll reassess them at 3 months. Simple. Right. And I just have that across the board.
Right, yeah. It's do you have all of this kind of in the patient leaflet, or do you do it on a specific case-by-case basis almost?
Yeah, so what's one of the really pertinent questions that I ask about in their history, and at that point I'll tell them. And then if I was to send them out a consultation, if I get the impression the patient's really they're not going to do it, I didn't get the feeling that they valued the treatment over smoking, then I don't send out a letter or anything. I just tell them, come back and see me when you stop smoking. Right. But you over time, with experience, you can sense patients that they know. So often patients come to see you and they know they have to stop smoking, because they were like, yeah, I knew you were going to say that, and I'm prepared to stop. And they're the patients you can send a letter to, put it in bold, type, this treatment plan is based upon, as we discuss, you stopping smoking, which I then plan to reassess in 3 months, etc., etc. So with this, you can gauge the patients that would look at, you know, stopping smoking. Yeah, absolutely. And I would encourage, especially starting off, you just don't treat smokers. It just complicates matters in no end, potentially. And, you know, why would you do that?
In terms of your patient consults, how long do they start off as, and kind of how long do you put now for an initial exam?
So generally the consultations are 30 minutes. So start to finish about 30 minutes. That gives me a time to just get the patient in, get them settled in the chair, introduce myself, my nurse, and just chat generally. I don't like to focus, you know, I think it's important to try to build up a rapport with the patient. That is really, really important, and not just focus on why you're here. You know, I take it completely off topic, or maybe the weather, maybe something about where they've come from. Often they've traveled quite a distance to come and see me at the various clinics that I work, etc., etc. Maybe I'll comment on what they're wearing, maybe their handbag, maybe their shoe, whatever, but I take the topic completely off and get them relaxed, chatting about it. Often when I'm working in England, the fact that I've got a Scottish accent, that kind of throws them a little bit, and that's often something that, you know, automatically always gets the patient started. You know, gets them to talk about a talking point for them. And often more than not, when I'm working in England, and it's quite often that I'm down south working, you know, we end up talking about where I'm from and what I'm doing here, and then I say, well, you know, I just travel down to work, etc., etc. But whatever it is, I think it's important to have a system in place where you try to, you know, break down the barriers between yourself and the patient and get them relaxed, because they're often already, you know, tense. They're coming to the dentist, and then they're tense. You know, it's potentially an extraction. You know, there will be a certain degree of anxiety, and you need to break that down. And then it just flows. You know, what can I help you with? What's been going on? And I think it's then important to really focus on their desires, their wishes, and being empathetic. You know, it's not an easy, you know, I think it's important to realize having a tooth out is a big deal. Just think about it, how you'd feel as an individual having a tooth out. I know, you know, it's not something I would be particularly happy about, having a tooth out, and then if that tooth is within the aesthetic zone, so near the front, then it's a big deal. It's a massive deal, and I think we need to be, you know, empathetic towards that. That's a big deal for a lot of patients, having to come here, potentially get a tooth out, and then have surgery to get an implant. And but you know, it's also a nice position to be in as an implant dentist, that I'm there and able to help these patients. So,
Yeah.
but all this process really, you know, it's 10, 15 minutes of rapport building, really getting to know the history. It is absolutely crucial. Medical history again, and then the social history, and then the examination, which is often, you know, if it's a tooth or a gap, it's pretty quick, but it's just the same as any other dental exam in terms of it starts off extraoral, intraoral, general assessment, perio, chart the teeth, and then focus on the site. And then when we focus on the site with an implant site, we're really focusing on the space. So it's the mesial distal space, the interocclusal space, the interradicular space, the buccal lingual, ridge width, the tissue, the occlusion, all those types of things. So numerous things, and then we take it from there. And then potentially, you know, I may have some imaging already available if the referring dentist has sent some imaging, but then it's you know, potentially I may do a CBCT scan. If it's a straightforward case, I'll be like, yeah, we'll just do that today. And often I quite like to do it on the day, and then get the patient down and sit with them and go through the scan. And then once we start taking a scan, and I'd like to then go through it with the patient as I look at it and let them know what I'm looking at, what I see. Then it may run over 30 minutes. You know, it may run over 30 minutes, but I also like to, you know, have a real air of confidence when I come across and let the patient know exactly what we're planning to do. You know, you've got a gap. So I don't see any problems here. We're going to put an implant, and I like to be that frank and honest with them. Can't see any issues here. It's a straightforward case, and I think patients appreciate that. They appreciate and they want someone that they can look to, that they can trust, and someone that airs confidence when they speak. And I think that's really, really important. And that only happens with experience, but it's something that you should focus on to come across as confident and assertive with the patient. And this is your options, you know, and the options are generally the same for most patients. They can have a gap and continue to have a gap once the tooth's removed. If the tooth's already gone, then they can have a gap. But that's not why they're there to see you. Or they can have a denture. But there's issues with dentures, you know, things that come in and out your mouth. They can be plastic or metal. They rely on the other teeth for retention. They rely on the soft tissue for support. They're clumsy. You know, you need to take it out in and out for cleaning. Or then bridge work. When I talk about bridge work, I'm like, well, you know, we potentially need to drill down teeth either side, and these teeth may be unharmed in the past. And then the final option is a dental implant. And it just happens automatically, and that's that's what you need to get into. But then I'm doing implants. That's all I do, and I'm talking about it every day. But it only happens with practice. It's like anything. It's just practice. And if maybe you're not doing them every day, but then you need to practice more. But it's important that you're able to practice coming across in a knowledgeable manner to your patients when you talk about these treatments. And I don't think, you know, the other thing is, I think it's important that, you know, regardless that you're placing implants or not placing implants, I think it's important that you're able to relay this information confidently to your patients, because as a clinician, you should be aware of these options and you should know the pros and cons of dental implants. And information on assessment of a site for a potential implant. I think, you know, there's no harm in developing those skills, because it just makes the whole process simpler. You know, if you're a principal in a practice or you're an associate, if you're a principal, it's a great way to keep income within your clinic. Yeah, because the alternative is, if you don't do implants, and there's nobody in the practice doing implants, you need to send patients out, and you're losing income out the practice. But what if you're the principal or the associate that's able to identify implant patients and talk confidently and get patients to sign up to that treatment in-house? Then you could potentially get a visiting implant dentist, someone like myself, and there's loads of us that go around practices doing implants. Come in, someone like myself, come in, we do the implant, and then back to the associate or the principal to restore. So most of the income that's potentially generated from a dental implant procedure is all kept in-house. It's a win-win, you know. And I think as clinicians, we need to think like that, especially now where, you know, we've taken such a financial hit by not being able to work within our clinics for the last 2 months, and who knows for how long. We want to try to keep, you know, genuinely every dentist, associate and principal will naturally want to keep income in-house. Why would you want to send implant work out? You know, simple implant work, you know, it's a way forward to keep it in-house. I get, you know, complex implant work, full arch, complex grafting, you know, that, you know, as an implant dentist traveling within clinics, it's not something I like to just do at any clinic. But the simple stuff, there's no reason why you can't keep it all in-house and then start to develop to restore.
Yeah, it's very satisfying when you can do multiple parts of the treatment plan yourself. It's comprehensive, patient, you know, stays with you.
Yeah, and you sort of bring it up with a patient in a manner, when you talk to them, you're speaking to them, look, you know, I think this would be suitable for a dental implant, etc. etc. This is my thought process. These are the other options. Now, if you go down the implant route, there would be someone else that would just assess it. He's a surgeon. He comes in, he places the implant, then I restore it. You know, etc. You know, and a patient, you know, because often it's your patient. They have that that relationship with you, and they're more likely to. If someone trusts you, they're more likely to buy from you. Yeah. You know, if you advise them, So if you trust someone and you're advising them about something, then they're more likely to take your advice because they know you and they have that relationship. And like, I was coming in, the patient's never met me, and I'm like, yeah, you've got these options, and a dental implant would work really well here. But I say to the patient, yeah, the cost is here, 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 and they're going to go, yeah, he's just trying to sell me something. But we know a dental implant is a great way to replace a missing a gap, and we know that it's a lot of the time the gold standard, and we know that it's over long term, it's cost effective. So it's not as if we're trying to just fleece our patients. We're actually trying to do the best for them. And
that's a good point.
more often than not, a dental implant is the best solution for a gap. But I appreciate patients can't always afford that investment at the start.
Yeah, I think last week I was kind of telling you how I was a bit cautious with dental implants, thinking there's so many risks, etc. But it gets highlighted that having a denture or having a bridge can pose more problems down the line, where you could be talking about 2 or 3 teeth being compromised rather than one.
Yeah.
So the biological and financial cost.
Yeah,
Very,
absolutely. Look, there is no there's no fix. There's nothing that's going to restore the natural tooth. Everything is a compromise. A gap is a compromise. If you leave a gap, you get drifting of teeth, you get food packing, etc., etc. Right? So you can't just leave it. If you give them a denture, there's compromise. If you give them a bridge, there's damaging to associated teeth either side. You give them an implant, there's a surgical procedure, there's potential complications, and then you put on a tooth, etc. And then there's a maintenance. In an ideal world, they shouldn't have lost a tooth. But you need to get that across to the patient. I think that's important. That what we're doing is a solution, but it's not a replacement for your tooth. We're replacing a missing tooth. We're not replacing the tooth. The tooth's gone, can't come back, and everything else is a compromise. And it's just about the risks versus the benefits, and for each option. And look, a lot of people have gaps. They function fine. People have dentures, function fine. People have bridges, they work really well. And people have implants, and they work well.
Yeah.
It's just about knowing about the different treatment modalities, and different treatment modalities will suit different patients.
Sure. Touching on something which I see quite often on social media, Instagram, Facebook, etc., is a lot of specialists and some of really people high up in the profession. They place implants in places where, for example, a previous perio patient fully stabilized. The teeth either side look like they have about 40% bone loss, and then they'll place an implant between 2 such teeth. Or you have a severe wear patient, probably erosive, not a bruxis caused, and they put an implant in at that OVD without being kind of comprehensive. Now, I know financial considerations are massive when you approach such cases, so kind of you can't make every mouth perfect, but like, where do you kind of draw the line? Because I'm not sure. The way I see it is, if a patient's spending £2,000-3,000 on an implant and going through the effort of getting one and all of that, it's really kind of, well, I wouldn't feel right not sorting out the rest of the problems first. And I know there are certain problems, like I said, bruxism, where you just cannot place an implant. It's not going to work. But, other cases where they have been severely compromised perio-wise, or you'd prefer them to get ortho and extractions, or so something else going on there. I mean,
yeah, it's not that bruxis can't have implants. I do implants for bruxis. Right. You just need to be aware of the occlusion. You need to be aware of that, and there's potential, aware of the restorative element. They can get screw loosening, etc. Right. It's not that's an issue. In terms of looking at the bigger picture for a patient, I think it's case by case. It's hard you can't really comment in terms of something you've seen on social media, because you just don't know the story about it. For instance, a perio case, maybe the patient said, I really want to, we'll look at something more long term down the line, but I just want this gap filled. And I've been in situations like that with patients. And you mentioned sort of say this, tooth wear, and ideally the patients say overclosed. You need to be sort of doing a full mouth rehab and then potentially look at filling the gap. Patients like, I don't want to go through all that. Just got this gap. Can you just fill this gap? And there's nothing wrong with that. So there has to, in an ideal world, we'd fixed everything and everything would be perfect and everybody have perfect straight teeth, but it's not like that. As long as you identify them, you appropriately consent your patients and let them know if you have any reservations about something in particular. I think there's no issue with certainly, more often than not, there's always a degree of compromise in your treatment.
Right, yeah. I mean, learning
it's not an ideal world. It's not an ideal world.
Learning a bit more about like what high level dentistry actually requires and getting into the costs of things, it's quite astounding, to be honest, And for example, I've seen many cases which the presenter says, look, I've presented the patient with 4 options. One was £70,000 where they keep their natural teeth, but we modify it in certain ways.
Mm-hmm.
And then another one was £10,000 where we remove all the teeth and put over implant dentures. And for a student, that sounds almost like, well, they make it sound in university like that's a massive, massive no-no. However, in the real world, it's quite important to realize financial considerations are there for the patients. Something that I'm starting to learn a bit more is that you can't save every tooth, and finances, once again, is a big thing. The national health is amazing and kind of does put that view in that we have to treat everyone on that equal level playing field, which is, of course, correct. However, I'm finding that outside in the real world, outside of the national health, things are really quite financially based, to be honest.
Yeah, absolutely. And that's a big part of the consultation process, is actually understanding the patient's budget and not coming across as a clinician that is for folks, but knowing a patient's budget is really important, and determining that at the consultation is really important, because there's some patients that simply can't afford the treatment, and you could go through all sorts, talking to them, tests and whatever, and they're like, yeah, my budget's £3,000, that's it, and they need a full mouth. So it is really important to approach budgeting, etc., with patients early on in the conversation, or if you're fortunate enough to have treatment coordinators, it's something that they often will approach with patients, because then they can be, put to the right person to see,
Right.
Because some patients are just not aware of the cost of dental work.
Yeah.
They thought they could get a full mouth. It's not unusual. I've had patients thinking they could get a full mouth of implants for, a couple of £1,000s.
Yeah. I mean, I think I've heard you'd be surprised as well who can afford treatment too. So it's always not good. It's good not to judge, and people who think,
100%. Yeah, absolutely. And I'm a big believer in this. If you can show it's important to be able to demonstrate value to your patients, then patients will find the money. Often patients will not go ahead with treatment because they don't value it. And as clinicians, it's our responsibility to show patients the value in the treatment we offer. Now, it's as simple as that. I get it. Some patients just won't be able to afford it. That's fine. But as a clinician, we should really focus on showing the value in the services we're offering. And then more often than not, patients will find the money somehow. Maybe it's finance. Maybe they'll come back to you in a year. Maybe they'll, and just save up. Maybe they'll go to the bank. Maybe they'll borrow some money, etc. If they value it enough, they'll find the money. And I think that's
absolutely. I mean, that's touching on that point, a very good kind of point, and that is lower dentures, for example, where patients come no teeth on the edentulous lower arch, and the lower denture is, they're not going to get along with it. Essentially, it's going to be a hassle. The only reasonable solution would be 2 implants in the lower overdenture.
Yeah.
Now, initially, that does cost about £2,000, £2,000, depending on who places the implants, where it's done, X, Y, Z.
Okay. bit cheap,
You
but
can correct me on that, right? Sure, you can correct me on that.
okay.
But in terms of the value, so getting the patient and yourself as well, the clinician, to realize, hang on, if I give them a lower denture, yeah, it might cost £200-300 on the national health or whatever. But if you look at the reviews that you'd have to do, the patient will keep coming in, taking up your chairside times. You'll have to keep doing adjustments, or they will never be happy. Once you've made that denture, you're kind of on the hook to kind of make sure it's functioning well, which,
Yeah.
as we know, it probably never will. So that could eat into that £2,000-3,000 that you could have used to place too many implants, for example. Or
okay, so it's interesting. You mentioned a lower and 2 implants. So there's a McGill consensus. I think it's 2002 McGill consensus. It was a group of clinicians that got together, and the minimum requirements for a lower dentures is for it to be retained by 2 implants. That's the McGill consensus. That's what they came up with. That actually having a lower denture is inadequate. This expert group deemed that a lower denture wouldn't really, give you adequate function, and the minimum that they required is 2 implants. And I think it's important to know that as a clinician and speak to patients about that the World Health Organization and the Guild consensus, it's a worldwide thing, is that the minimum standard for a lower denture is to be retained by 2 implants. So RP5 design from the Misch classification. And it's an important thing to note, when we give patients fulls, that we educate them and say, you will struggle with this because we've got minimum standards, and the minimum standard is 2 implants. And the sad thing, unfortunately, it's not available in the NHS, but, we know you'll struggle with this.
Yeah, and even I'm not sure how true this was, but the speaker that was presenting that interesting point, he said the amount that a patient would use in denture adhesive added up over 5-6 year period could actually end up being a lot of money, essentially.
Okay. Well, I haven't thought about that, but yeah, absolutely. Absolutely. And maybe you can, you could draft up something for patients where you give them a scenario. These are dentures, and often you need adhesive, and adhesive costs, I don't know, £4.50 a tube, and you need a new tube every 2 to 3 weeks, and this is the cost of a year, and compare it with implants. And that's, I think that'd be a nice illustration to show patients, potentially what the cost long term is. And I think, it's that fine line. You don't want to come across too pushy to patients. Certainly you don't want to be coming across as a salesperson, but it's just sort of putting it in a nicer way as possible, and in a genuine way. And I'd like to think we are coming across genuine. And then it goes back on to the point that we raised earlier, is that if that person is that person that they have a trust relationship, a long-term relationship, it's so much easier for them to then accept the treatment. I think that's really important.
Absolutely. So going on to implant systems out there, so not going into too much specifics, but we all know that there are expensive implant systems like Straumann, Neos, all of them, and then you have the cheaper implants. I think it's Sun Direct is a brand that comes to mind for some reason, but obviously you get what you pay for. So I'm not trying to say there are no differences, but in your opinion, what are the main differences, and could you present, so for a patient who you know to be financially constrained, could you present a cheaper alternative over, let's say, what you'd prefer to place?
Okay, so I think, maybe that's an option. So I use a particular system, and it's not just about the implant, it's so much more. It's the support, it's the relationship I have with that industrial partner. I think the cost issue, it's not just about the components. I think that's important. Certainly every system has pros and cons, but as a clinician, you need to look at it as a bigger picture. It's not just, you shouldn't see it just as buying an implant and buying components and etc. Cost absolutely does come into it, but what else are you getting from a company? And different companies offer different types of support. Maybe they offer business development support. Maybe they'll offer personal support to yourself as a clinician to develop. Maybe they'll help you build up a refer and restore program within your local area. So there's so much more. So, you know, it's easy to look at some implants and others that are, you know, maybe the top 5 implant systems in the country, and look at them, and there's a wide range in cost. That is what it is. But certainly they're number one because obviously there's something, you know, people get good results. And at the end of the day, you know, what's a 100, 150 pounds working with a system that you know works in your hands? Why would you change? You know, 100 really doesn't come to it. You just want those results. You want to work with something you're comfortable. You want to work with something that has given you those results over a long period of time. So clinicians at implant dentists are reluctant to change system. Most of them are. But what I would say in terms of the cheaper systems, I mean, I don't go there. I don't really have experience. I've said it before. I think it's important to stick to repeat, you know, a more well-known brand. I think that's important. And then they have the support. You know, it's not just about the well, but they have that support, day-to-day support. Maybe you've got an implant that was then placed 10 years ago. You can still get components, etc. I think that's really, really important. You touched on, you know, maybe you could use a cheaper system and a more expensive system and give 2 different price ranges. I don't see an issue with that. Absolutely. You know, you can give patients an option A, option B. Certainly some implant systems really are, you know, really quite markedly more than others. And maybe you want to, you know, so for instance, if I give you an example, if I was to do a full arch, maybe the component cost is just over £1,500 for the surgical part. Another system, it may be closer to 2,500. Maybe you can give patients that option. You know, maybe you give patients that option and give them, you know, we've got this system and this system, and one's just the cost is more. But, you know, is one system better than the other? I think that's difficult to prove. You know, that's all you can say, because for me, you know, if I was to just sort of think about me doing it in my clinical practice, you know, I'd find it hard because I'd get equally good results with either system. So that's the difficult thing. Unless I went really cheap, but I wouldn't do that because I really wouldn't be happy using an implant that was maybe 60, 70 pounds or 50, 60 pounds. It was, I don't know, made in China or whatever. You know, I just wouldn't be comfortable doing that. So I'm just going to see, I think someone's posted a question.
No problem, yeah.
Unless I went really cheap, but I wouldn't do that because I really wouldn't be happy using. Yeah, I mean, someone's just mentioned that, you know, looking at the support you get from systems, absolutely 100%.
Right.
You know,
right,
I get superb support with BioHorizons, who I work really closely with. But that's not to say if I didn't work with Straumann, I wouldn't get the same level of support. I work closely with Straumann as well, and I get good support from them. I was speaking to one of their representatives this morning. You know, I think whoever your industrial partner is, you need to build up a close relationship. It's so important. They will help you grow as a clinician. They will help your practice grow. And I've said it before.
Those reps are amazing.
It's really important.
Seen a few webinars given by some of the reps, in fact, and they're so knowledgeable on how they guide clinicians. Very good. Yeah.
Any other questions, was it, Vishal? We've been talking for about 40 minutes.
We have, yeah. Here's a random question to throw in there. Is it acceptable to only use an OPG when placing an implant?
No, I wouldn't say, because I'd want a periapical. You know, the majority of my implants, I have a scan, maybe 98%, 99%. Sometimes I work in clinics that are more rural. So I've got a clinic up in Oban in the north of Scotland, and you know, it can be a real effort because the patients are coming from an island to see me, and then I have to send them an hour and a half, 2 hours, maybe down south to Glasgow or further north to Inverness. Inverness, yeah, I think so. I get mixed up, but they have to go further north to get a scan, and maybe they're not mobile. Maybe it's really difficult for them to get to a particular area. So for those patients, if it's straightforward, if I can take an X-ray and I'm happy, then those are the patients I would happily do an implant without a CBCT, but the majority of clinics I work in have a scanning machine, and I utilize that. So there are, I wouldn't say 100% of the time, but the vast majority of times I'm utilizing a CBCT. But
Okay.
look, there's clinicians, I trained in an era where CBCT was readily available and it was cheap. But there's clinicians that have been around for a long, long time, and they've done probably more implants without a CBCT than with a CBCT. So who am I? Who am I to say that they shouldn't be doing it without a CBCT? Absolutely. I think it's a lot of it is up to clinical judgment from the treating clinician.
Right. Touching on posture during implant dentistry, you don't use a mirror. So like I've seen lots of people when they're placing it, they're in all manner of positions because you're working in awkward positions in the mouth as well. Is that something you developed?
Yeah, I wouldn't say my posture's great. Thankfully, the surgical part, you're not doing surgery all day, every day. So you get a rest, but yeah, you need to have strong neck and shoulder muscles.
What magnification are you using?
So generally for implant work, I'm not using any magnification. Right. But if I was to do soft tissue surgery or bone grafting, then I would use 2.5 with my light. But otherwise, I like to just have no magnification. When I initially started, I did use magnification placing implants, but actually I found that my implant treatment was better. My implants were straighter and better mesodistally, buccolingually, if I didn't use magnification. So I've continued that way, and I've been like that for a number of years.
Right, so, yeah, the field of view is probably a bit bigger. So
yeah, absolutely, and that's what it comes down to. Yeah, your field of view is much better.
Quick question about textbooks or list of landmark and important papers that any young dentist should read who wants to get started in implant dentistry. Do you have like a collection of them? I know ITA, like you said, do a lot of consensus reports, and they're very good to read. There are lots of other great societies out there that will kind of give you an update on the literature as well.
And like I've said, I'm an ADI committee member. We do a lot of really good study clubs, and with lockdown, we're going to be doing a number of webinars, and then hopefully we do a number of educational events, etc. The ITI similar, they do study clubs. They're free for members. Their online academy is fantastic. I'm a member of both, although I'm a committee member of the ADI. In terms of books, I'm looking at in front of me, and I've got a number of textbooks in front of me. I've got the Contemporary Implant Dentistry, Carl Misch's book. I've got Vertical and Horizontal Ridge Augmentation from Esteban Urban, which is a bit more for complex grafting. And then I've got Plastic Aesthetic Periodontal and Implant Surgery from Zur and Herzler, and that's a big pink textbook. So, and that's the textbooks right in front of me on my desk.
Great textbooks.
But then, so I can't say I look at a huge amount of textbooks. I've got loads more other textbooks, but I think starting off, it's good to just have a basic textbook. So Misch's Implant Dentistry, I think it's really well known. Just a much more basic textbook, and then you build upon it. And as you read more, then you can start looking into the literature more, etc., rather than, you'll just be sort of bamboozled with data and etc. It's not the funnest thing, often reading through journals. So I would say, just a general textbook, get your course, start learning, start building up your experience within implant dentistry, and then you can take it further. And then you'll start to develop a real passion for it. And then if you do, then you'll really want to explore the literature more, and then you're more likely to then take that in if you enjoy it, rather than, I want to do implants, so let me just look through the literature. I think there's a good chance you're just going to be put off. So just take it in steps.
Absolutely. Last question. Like you said, we've been talking for a while, so thank you very much. Financial considerations for young dentists, dentally and non-dentally, if you have any wisdom. How to get the right balance as well between business and clinical earlier on in your career because that is something right now I find myself and a lot of my peers were very clinical focused, and we're getting very caught up in a millimeter here or a millimeter there, where in reality, like you said, patient management, communication, business is a massive aspect as well. So kind of, if you were starting off again, what kind of advice would you give yourself from a financial standpoint?
Yeah, from a I spent 9 years at university, and I was way behind my peers in terms of financially, and student debt, etc. Because I focused on upskilling, I focused on learning, developing, and then I always felt that the earning would come. And like I've said before, focus on the learning before you focus on the earning. It's absolutely crucial. Another thing a colleague once said to me, and I think it really, has stood by me, is he mentioned that, every year he sets aside a percentage of his income. So I think it was maybe 10%, 15 every year, and he looks to invest that in himself. So, and I think that was something that I was like, yeah, absolutely spot on. So every year, whatever it is, set that money aside, 10%, 15%. I'm going to invest that in myself. Whatever it is, doesn't necessarily just need to be dentistry. Whatever it is, invest that in yourself to improve yourself. Warren Buffett, he talks about, the best thing you can do is invest in yourself. You can't be taxed. Knowledge, no one's going to tax you on you acquiring more and more knowledge, but when you acquire more and more money, you're going to get taxed more and more. It's as simple as that. So, really, especially early on, and actually it never stops, is really, really focus on knowledge and learning from other people and picking courses wisely. But have a system in place as well. Just don't blanketly just randomly go on courses. Have a plan in place, and then focus your learning around achieving those goals. I think that's absolutely crucial. So your money's not being wasted. The worst thing, So and what you often hear about is, and again I've spoken about it before, is people going on courses and then coming back and not practicing what they've learned, and they've spent X amount of thousands on a course, and then they've come back and not putting it into practice. And I think that's just a real shame. So one thing I encourage people is, before they even embark on a course, it's important to have a plan in place where what you're going to learn from the course, how are you going to put that into practice straight away when you come back. So for example, we did a bone grafting course recently. I did it with my colleague George, and I said to some of them, you've come on this course and it's advanced bone grafting. So when's your patient? When are you planning to start practicing what you've learned? They had no plan. They had no idea. Some of them did, some of them didn't. And I was like, so you've done a course, and on Monday morning, when we finish this weekend course, this is when it's going to be freshest in your mind. So the best time is next week to start getting those patients in and start doing the treatment. And that's what I would say. When you're going to course, go on the course because you've already got patients that you've identified on a waiting list that need the treatment that you want to learn, and then get the right equipment to carry out that treatment, and then get started. Maybe you need mentored, get a mentor, get that all in place before you start embarking on a course. And then, or wait, you've done a course, and then 6 months later, you start to, put into practice what you've learned. I don't think that's ideal. You want to do it fresh. You want to have it fresh in your mind, and then really put it into practice the following weeks. Straight after you've completed a course. I think that's really, really important. So yeah, in summary, I would say, have a set amount every year that you look to reinvest into yourself, into your learning. Have a plan in place before you just go on random courses. Have set goals for yourself in terms of your learning. So pick the courses, and then make sure what you learn from the course you're able to put into practice straight away.
Yeah, no,
and that way you get the most out of it.
In terms of the business side, it's very true. I mean, I watched a very simple webinar on business for post-COVID, how practices should proceed, for example.
Right.
And it's quite interesting to note how technical it is. You know, there's so many figures and things you need to stay on top of. But one thing which was highlighted was return on investment. In normal times, return on investments, you count that in the chunk of your profits. You want a return on your investment. So that's really highlights what you said about investing in yourself, and 5-10 years down the line, you will get it back as a return on investment.
Yeah, and it's important. Yeah, and it's important to think about that. You know, even at the start when you're thinking about doing a particular course, what you think about the return on investment. I think that's important. Someone's mentioned something. Pick out what did what I asked about. They will help you with implant marketing. Yeah. So yeah, someone watching in raises a very good point. Craig, thank you for that comment. And although we've not touched on it, I have a really good relationship with my lab and the technician I work with. The work that I do, you know, relies on the support within my practice, but equally relies on support and teamwork with my technician. You know, a big shout out to Kevin. I don't know if he's listening, who I've worked really closely with for a lot of my full arch work. And he's a fantastic prosthodontic technician. He's a CVT. But, you know, it's really, really important you build up that relationship with labs as well and work closely and being able to communicate freely with them. You know, I've been keeping in touch with Kevin throughout this whole lockdown procedure process. You know, on a weekly basis, I chat to him 2 to 3 times a week about cases. I think that's really, really important, really, really important. And, you know, all the lab guys that you work with, you want to build up that relationship with.
Certainly, I would second that. Absolutely. Yeah. All right, lovely, Farnaz.
You've
exhausted all my questions, so thank you very much.
Thanks.
Really appreciate it.
Great. Thanks for everybody tuning in, and I'll see you again tomorrow. Bye-bye.
Awesome.